Today we are going to cover Chapter 48, Drugs Affecting Coagulation. And this chapter is in your Tucker and Karch pharmacology book. To understand the drugs that we are going to talk about, you need to understand the process of hemostasis. And you have talked about this in MedSearch 2 already, but I'm going to do a quick review over it so it makes a little bit more sense when we talk about the medications that you're going to see that are going to affect our coagulation. So when a blood vessel is injured, the first response is a temporary narrowing of the vessel or vasoconstriction. If the injury is small, this constriction may close the break and allow healing. Larger injuries can take a little bit longer. Vasoconstriction is going to be caused by muscle spasms, nerve signals, and chemicals released from the vessel's linings and platelets. In small vessels, platelets release thromboxane A2, which helps tighten the vessel further. The injury also exposes substances under the vessel lining, which activates platelets in the blood. These platelets change shape and release chemicals that make them sticky, allowing them to bind to the collagen and von Willebrand factor in the injured area. Platelets use glycoproteins to stick to tissues, fibrinogen, and other platelets. Once attached, they release substances like ADP and serotonin, attracting more platelets to clump together and form a plug. Thromboxane A2 helps by promoting both vasoconstriction and platelet clumping, which together form a platelet plug that can stop the bleeding and protect the circulatory system. The next step in hemostasis is turning fibrinogen, a protein in the blood, into a fibrin clot. This happens through two pathways, intrinsic and extrinsic, which work together to form the clot. The clotting process follows a specific sequence with many clotting factors in the blood being inactive until they're needed. Most of these proteins are made in the liver, and vitamin K is needed to produce several of them. Calcium is also essential to activate many of these clotting factors during the process. So when we look at dysfunction of hemostasis, we can either have where we clot too much, or we can have bleeding. So thrombosis, think pulmonary embolisms, DVTs. Bleeding, think hemorrhaging. So now I want to talk a little bit about the pathways involved in coagulation, as well as clot resolution and the anti-clotting process. So first, we will talk about the intrinsic pathway. When blood contacts the exposed collagen in an injured blood vessel, a clotting factor called the Hageman factor, or factor 12, gets activated. This triggers several reactions, which include clot formation, clot breakdown, and the start of inflammation. First, the Hageman factor activates clotting factor 11, which then triggers a chain reaction called the intrinsic pathway. This leads to the conversion of prothrombin into thrombin. Thrombin then breaks down fibrinogen into fibrin threads, which form a clot or thrombus inside the vessel, thus sealing the injury. While the intrinsic pathway forms a clot inside the blood vessel, the extrinsic pathway clots the blood that has leaked into the surrounding tissues. Injured cells release tissue thromboplastin, which activates clotting factors in the blood and start the clotting process outside the vessel. The injured vessel is now constricted with both platelet plug and clots inside and outside the vessel. This keeps the circulatory system intact. Both the intrinsic and extrinsic pathways eventually merge at the activation of the Stewart factor, or factor 10, to complete the clotting process. In the common clotting pathway, in the presence of calcium, activated factors 10 and 5, along with phospholipids in the plasma, form a complex called the prothrombin activator. This complex splits prothrombin into thrombin. Thrombin then converts fibrinogen into fibrin fibers, which combine with platelets, blood cells, and plasma to form a clot. When looking at clot resolution and anti-clotting process, the blood plasma contains substances that prevent excessive clotting, which could block blood vessels. For example, Antithrombin 3 slows down clotting by preventing thrombin formation, reducing fibrin threads. Proteins C and S also act as anticoagulants by deactivating clotting factors 5 and 8. Plasmin, which is another substance in the plasma, dissolves the clots to keep blood flowing freely. Plasmin is made from plasminogen, which is produced in the liver. The conversion of plasminogen to plasma is triggered by factors like stress, physical activity, and certain hormones. Plasma is especially important in the lungs and uterus where it helps maintain blood flow. Its effects can be seen during menstruation where clots form slowly, allowing the uterus lining to shed over days. This is just a picture of the process of blood coagulation. Shows the blood vessel injury, our intrinsic pathway, extrinsic pathway, as well as the actions that happen with the blood vessels. So showing our plug here with our platelets and fibrin that form the clot. And now I want to talk a little bit about drugs affecting coagulation across the lifespan. It is good to look over this box 48.1 in your book, but for children, the use of anticoagulants, antiplatelets, and thrombolytics is still developing. More research is needed for safe practice, so they are less commonly used in children. When used, careful monitoring is required to prevent excessive bleeding, which can be caused by drug interactions or changes in the liver or digestive function. Caregivers need to take extra precautions to prevent injuries and know how to respond if the child starts bleeding excessively. Because of limited evidence, guidelines often vary by institution. Low molecular weight heparin is the preferred anticoagulant for children, though heparin and warfarin are commonly used as well. Adults taking these medications should take steps to avoid injury, like using electric razors, a soft toothbrush, avoiding contact sports. If they start bleeding, they should apply firm pressure and contact their healthcare provider. They need to know the signs and symptoms of bleeding and report them. Since many medications and supplements can interact with these drugs, patients should inform healthcare providers and check all medications before combining. Wearing a medic alert identification is recommended for emergencies. For older adults, they often need more medications that can alter clotting for heart disease, stroke, or certain circulation problems. They usually take more medications, which can lead to more risk of drug interactions. Also, age-related liver and kidney issues can affect how these drugs work and are cleared from the body. So before starting treatment, older adults should be checked for any liver or kidney function issues, their medications, and their ability to keep up with the regular blood tests. For example, if we're going to start them on warfarin, we need to be sure they're going to be able to come in and have their INR checked as frequently as it needs. They need to have their medication regimen monitored very closely. Disorders that are going to affect our blood coagulation. So thrombolytic disorders are going to involve blood clots that can block or reduce blood flow, leading to symptoms like low oxygen, tissue damage, or tissue death. Hemorrhage is going to be disorders that can cause excessive bleeding. So hemorrhagic disorders can include hemophilia A, liver disease, thrombocytopenia. Medications that affect clot formation and resolution are going to be your antiplatelet agents. These alter platelet aggregation and formation of platelet plugs. Anticoagulants, which will interfere with the clotting cascade and thrombin formation. And thrombolytic agents, which will break down the thrombus that has been formed by stimulating the plasmin in the system. These are some of the antiplatelet agents that you should be familiar with. Commonly, aspirin, Plavix, Brilinta, and Aggrastat are seen out in practice. Our prototype is aspirin. It's indicated to reduce the risk of death and MI in patients with chronic coronary artery disease. These are going to be patients that have a history of MI or unstable angina or chronic stable angina, reduction of the risk of death and recurrent stroke in patients who have had ischemic stroke or transient ischemic attacks. It's also indicated for use as an analgesic or fever reducer. So this action, it inhibits prostaglandin synthesis, resulting in inhibition of platelet aggregation. Some adverse effects can be acute aspirin toxicity, possibly leading to fever, coma, CV collapse. We may have nausea, dyspepsia, heartburn, GI bleeds, occult blood loss, dizziness, tinnitus, difficulty hearing, and anaphylaxis. So again, for antiplatelet agents, therapeutic action is going to inhibit platelet adhesion and aggregation by blocking receptor sites on the platelet membrane. Indications again, for certain CV diseases, prevent cerebral vascular occlusion, peripheral artery disease treatment. Also can be an adjunct to thrombolytic therapy in the treatment of MI. Our choice of the drug is going to depend on its intended use and how patient tolerates the adverse effects. But it is generally well absorbed, metabolized in the liver, and excreted in the urine. And it does tend to enter human milk, so caution should be used in those that are breastfeeding. Contraindications will include any allergy or contraindication to specific for each agent. So our cautions are going to be any type of bleeding disorder or active bleeding, if they've had recent surgery, if they've had a closed head injury, pregnancy and lactation. Our adverse effects, of course, I've already talked about: bleeding, GI issues, skin rash, and drug-to-drug interactions. If they're taking any other type of anticoagulant, antiplatelet, thrombolytic, it can alter the effects and increase the effects of bleeding. Anticoagulant agents. So these are going to be common that you're going to see are going to be your Lovenox, Coumadin, or warfarin, heparin, Pradaxa, Xarelto, Eliquis. Let's see, Gatriband is prescribed a lot as well. Our prototype for this anticoagulant is heparin. So it's indicated to prevent and treat venous thrombus, or DVT and PE, treatment of AFib with embolization, treatment of DIC, prevention of clotting in blood samples, and heparin lock sets, and it is an adjunct in the treatment of MI and stroke. It inhibits thrombus and clot production by blocking the conversion of prothrombin to thrombin and fibrinogen to fibrin. Our adverse effects is going to be bleeding, epidural or spinal hematoma, heparin-induced thrombocytopenia, hypersensitivity reactions. It can cause loss of hair, bruising, chills, fever, osteoporosis, and it can suppress renal function if it's used long-term. So again, our therapeutic actions is that these anticoagulants interfere with the normal cascade of events involving the clotting process. It does vary a little bit depending on the drug. Indications, again, are going to vary depending on the drug. But for example, warfarin is going to maintain a state of anticoagulation in which patients are susceptible to potentially dangerous clot formation. So for example, they may have chronic PEs or pulmonary embolisms or DVTs. So they may have to stay on an anticoagulant for life. They may come in the hospital on heparin and then transfer over to a PO form of an anticoagulant. Dabigatran reduces risk of stroke and systemic embolism in patients with non-valvular AFib, and it also treats and prevents recurrence of DVT and PEs as well. Pharmacokinetics, again, vary by specific agent. Our contraindications are going to be any allergy to these medications, conditions that are going to cause increased bleeding tendencies. Warfarin, if we're pregnant, we don't want to give that. Generally, we'll stick to heparin. And then we want to use caution in renal or hepatic disease. Drug-to-drug interactions, so other drugs or substances that are going to increase our risk of bleeding. Warfarin has a ton of different drug interactions, so we always want to check for giving medications that it's not going to interact. We need to educate our patients. If you're on warfarin, make sure you talk to your physician first. If you're going to take any type of over-the-counter substance, multivitamins, vitamin C, anything like that, they need to talk to their provider. Thrombolytic agents, so this is alteplase, reteplase, and tenecteplase. Our thrombolytic agent prototype is alteplase, and we will see this used for treatment of MI, acute pulmonary embolism, and acute ischemic stroke. Also, it can be used to restore function of an included central venous access device. So if you are out in clinical and you have someone that has a PICC line or central line and part of the access is clogged, and they call the PICC team or IV team and they put a medicine in there to help unclog it, it's a small tiny dose of alteplase. Therapeutic action is it works to activate natural anti-clotting system, activates tissue plasminogen. It's effective only if patient has plasminogen in the plasma. Indicated again for dissolution of a formed thrombus. So if we have a acute MI, we often will give it if they meet criteria for ischemic stroke. You want to try to give this medication as quickly as possible in a certain time frame because it's going to help dissolve that thrombus and preserve brain tissue. Contraindications are going to include any allergy. You want to use caution in any condition that could be worsened by dissolution of clots. So if they've had recent surgery, a head injury, anything that could cause hemorrhaging, this is going to put them out from having any type of alteplase or thrombolytic agent. Adverse effects, of course, are going to be bleeding, cardiac arrhythmias, hypotension. They may have mental status changes, and of course, hypersensitivity reactions. And interactions are going to be any type of anticoagulant or antiplatelet drug because it's going to further enhance the risk of bleeding. Anticoagulant adjunctive therapy. So this can include Indexa, and this is used for patients on abixapan with severe bleeding and they need a reversal. So these are essentially reversal agents. Praxpine is used for dabigatran needing urgent reversal due to surgery or severe bleeding. It's administered via IV bolus. Protamine sulfate, prothrombin complex, concentrate, and vitamin K. These can be given as reversal agents for possibly Lovenox, warfarin, heparin. And there are boxes in your book, 48.4 and 48.5, that has more details about these medications. We also have hemorrhagic agent, which is pentoxifylline. This can actually induce hemorrhage. It decreases platelet aggregation and decreases fibrinogen concentration in the blood. So that's going to cause a decrease in blood clot formation and increases blood flow through narrowed or damaged vessels. It is associated with many cardiovascular stimulatory effects, and these are going to include things like flushing, chest pain, arrhythmias, hyper or hypotension, and tachycardia. Bleeding disorders include hemophilia, liver disease, and bone marrow disorders. And we treat these often with anti-hemophilic agents. So what this does is it replaces factors for the specific clotting factors that are genetically missing in that particular type of hemophilia. So I have anti-hemophilic factor, coagulation factor, or NOVO7, coagulation factor 7, factor 9 complex, anti-inhibitor coagulant complex, and factor 13. Our prototype is anti-hemolytic factor, so it's going to be treatment of classic hemophilia to provide temporary replacement of those clotting factors to correct or prevent bleeding episodes. So it's indicated to prevent blood loss from injury or surgery, treat certain bleeding disorders. And again, the drug of choice is going to depend on the particular hemophilia that's being treated or the coagulation abnormality. Contraindications to anti-hemophilic agents include any allergy, liver disease with signs of intravascular coagulation or fibrinolysis. Caution needs to be used in pregnancy. Again, adverse effects can include risk associated with the use of blood products, so headaches, flushing, fever, chills, lethargy, nausea, and vomiting. They also can experience stinging and itching or burning at the site of injection. Hemostatic agents, so we can have systemic agents such as aminocoproic acid or Amicar. We also can have topical agents, so adsorbable gelatin, human fibrin sealant, microfibrillar collagen, thrombin, and thrombin recumbent. Therapeutic actions for systemic is going to inhibit plasminogen activating substances. It's indicated to prevent body-wide or systemic clot breakdown to prevent blood loss. And topically, we're going to use this for surface injuries that involve so much damage to the small vessel area that clotting cannot occur. Or we have slow bleeding, so we have continuous blood loss. Systemic-wise pharmacokinetics, it is rapidly absorbed and widely distributed throughout the body. Topically, it's available in sponges, sprays, and topical solutions. Contraindications for systemic, of course, it's going to be allergies or acute DIC. Topical, for thrombin specifically, any allergy to bovine products. Caution, systemically, cardiac disease, renal or hepatic dysfunction, pregnancy, and lactation. Adverse effects that we can see with systemic hemostatic agents is excessive clotting, central nervous system effects, GI effects, weakness, fatigue, malaise, and muscle pain, intrarenal obstruction, and renal dysfunction. Topically, we can see infection. This essentially with the use of the absorbable gelatin and microfibrillar collagen can pose a risk for infection because bacteria essentially can become trapped in the vascular area. If we suspect infection, we need to immediately remove the sponge and clean the area to decrease infection risk. Drug-to-drug interactions. So aminocoproic acid is associated with the development of hypercoagulation states if it's combined with oral contraceptives or estrogen. The risk of bleeding also will increase if it's given with heparin. And topically, there are no drug-to-drug interactions reported.